All right. Sarah's current chief resident here in internal medicine at Virginia Commonwealth University. She completed her undergraduate studies at the University of Central Florida and received her Bachelor's of Science degree in Health Sciences. Following that, she went on to medical school and got her degree from Campbell University Osteopathic School of Medicine. And then upon completing her chief year, she will go on to pursue a fellowship in cardiovascular disease at the University of Maryland. So I introduced you, Dr. Sara Kwiatkowski.
Good afternoon, everyone. Thank you for joining me for our last CPC of the year. I might be biased, but I do think we saved the best for last. So getting right into it, we'll start with a general overview of my case presentation today. That will take around 5 minutes. Hopefully, we do have a lot of information to present, but I'll try to keep it short. We'll then I'll turn this over to our case discussant for a dissection of the case that will take around 25 to 30 minutes. We'll hear from an expert for around 15 minutes, and then we'll have 5 minutes at the end for questions. So history of present illness for this patient. She's a previously healthy 40-year-old Black female. She was brought to VCU by EMS following a witnessed seizure episode. The patient's family sought medical assistance upon discovering the patient in an unresponsive state, experiencing generalized shaking and urinary incontinence. On EMS arrival, the patient was found lying down with frothy secretions emanating from her mouth. En route to the hospital, she experienced a witnessed tonic-clonic seizure, necessitating intubation for airway protection due to a tongue laceration with uncontrolled bleeding. In discussions with her family, they convey that the patient was at her baseline state of health until the past few months when she developed unintentional weight loss. In the days leading up to the incident, she had been expressing discomfort with headaches, which she managed with ibuprofen. She is studying to become a nurse and had an exam on the day prior to her presentation. The family denies any recent illnesses, exposure to sick individuals, travel, or introduction of new medications. Further history and review of systems was not obtainable as she was intubated and sedated on arrival to VCU. So no past medical or surgical history, as I mentioned. She has been using ibuprofen, 400 milligrams every 6 hours for headache. She has no known drug allergies. She lives in Richmond and works from home. She is sexually active and has an IUD. She reports occasional alcohol and tobacco use, but denies other drug use. She denies recent domestic travel and has never traveled internationally. She has 1 dog and no other pets. In terms of her family history, she has a family member with diabetes. She has 2 adult children who are healthy, and there is no known autoimmune disease or cancer in her family. Moving on to her physical exam, the patient was afebrile on arrival with a temperature of 37.8 degrees Celsius. She was hypertensive with a blood pressure of 173/113, tachycardic with a heart rate of 104, tachypneic with a respiratory rate of 22, and she was setting well on her ventilator settings. In terms of her physical exam, she's a thin, well-kempt female. She appears her stated age. She was normocephalic and atraumatic with moist mucous membranes, anacteric sclera, and her neck was supple with no thyromegaly, or JVD. She was tachycardic with a regular rhythm. No murmurs, rubs, or gallops were appreciated. Her pulses were normal, and her extremities were warm. She was intubated with clear lungs bilaterally. On abdominal exam, her abdomen was soft. She had no grimace with palpation, rebound, or guarding. She did have hepatosplenomegaly. On skin exam, she had no jaundice or bruising. She did have multiple tattoos, and there was a tattoo on her right deltoid with overlying erythematous changes. In terms of her musculoskeletal exam, she had no joint swelling, tenderness, or erythema, and neurological exam unable to be assessed as she was sedated. Moving on to her laboratory studies, her CBC was notable for a hemoglobin of 11.8, which is low, and low platelets 125. Her BMP showed hyponatremia of 134, normal potassium and chloride, low bicarb of 20. Her BUN and creatinine were normal, as was her glucose. Calcium was elevated at 13.8, and her MAG and phos were both normal. Hepatic panel notable for an elevated alkaline phosphatase of 825. Her infectious workup was largely unremarkable, including her Aspergillus studies, Fungitel and Platelia, her cryptococcal antigen, coccidioides, histoplasma antigen, Bartonella, blood cultures. Quantiferin gold was indeterminate. Her AFB cultures were negative. HIV, hepatitis, viral serologies were also negative. She had a PTH of 6.6, which is low. Her PTH-RP was undetectable. Vitamin D was elevated at 447. Her 125 vitamin D. Her 25 vitamin D was low. ANA, P, and C ANCA were both negative. Her SPEP was negative, and her GGT was elevated at 482. Moving on to her imaging, she had an MRI brain with and without contrast that showed increased T2 flare signal within the bilateral occipital lobes, right posterior temporal lobe, and right high frontal lobe without associated enhancement or diffusion restriction. These findings were concerning for press. Alternatively, these findings may have represented non-hemorrhagic parenchymal contusion related to seizure activity. There was no abnormal brain enhancement or intracranial mass noted. She had a CT chest that showed a 3.4 by 2.4 centimeter cavitary lesion in the left upper lobe with associated solid spiculated nodule adjacent to the inferior aspect of the cavitation. She had multi-station intrathoracic adenopathy as well. Her CT scan also showed widespread bilateral airspace disease with no lobe spared, and this was concerning for infection with or without aspiration. She also had a CT abdomen pelvis, which showed marked hepatomegaly and moderate to marked splenomegaly. There were innumerable tiny lesions throughout the liver, as well as the spleen. These findings were concerning for metastatic disease, lymphoma, or disseminated infections such as tuberculosis or candidiasis. There was a small to moderate amount of ascites, and then the abdominal scan also reiterated those findings from CT chest. And lastly, she had scattered small geographic sclerotic skeletal foci. Try to say that 5 times fast. And one more additional test was obtained to confirm the diagnosis. So with that, I will turn it over to our case discussant, Morgan Vargo. Dr. Morgan Vargo graduated from VCU School of Medicine in 2014 and subsequently completed her residency in internal medicine at VCU in 2017. She then continued at VCU as a chief resident in 2017 to 2018. She completed fellowship in endocrinology at VCU in 2020. In addition to practicing endocrinology, she is also board certified in obesity medicine. She left VCU in 2020 at the completion of fellowship to join a private practice here in Richmond, and then returned to join the Division of Endocrinology at the Central Virginia VA Medical Center in 2023. I will turn it over to Morgan.
All right, thanks for having me. It feels like time's flown. 2018, I was in Dr. Kwiatkowski's shoes and tried to stump Dr. Dan Markley, and I don't think that was successful. So honored to be here. Thank you for the invitation, and we'll see how we go. I think Sara sent me this case, and I wrote back, wow, there's a lot going on if this was a real patient, and I hope the patient is doing well. What I extracted from the patient's presentation was some things that I highlighted. She presented with a seizure. I'm not a neurologist, but we can't ignore that. She had some unintentional weight loss, notable headache. She was quite hypertensive, also tachycardic. The imaging showed hepatosplenomegaly. Someone was very astute and noticed a rash over her tattoo. She was thrombocytopenic, mildly anemic, and then also hypercalcemic. But there was more, a left cavitary upper lobe lung lesion next to a solid spiculated nodule, multiple areas of mediastinal adenopathy with widespread bilateral aerospace disease. There were lesions through the liver and the spleen, and also sclerotic skeletal foci in the pelvis on the CT. So she came in with a seizure, so I think we have to address that first. The brain imaging showed no intracranial mass, but did show abnormal signaling in the bilateral occipital lobes, right posterior temporal lobe and frontal lobe. And our radiologist gave us that this may represent PRES. So I had to go figure out what PRES is and how that might relate to this patient's case and whether we thought that was going to lead us to a diagnosis. PRES is a syndrome that can include a headache, a seizure, altered mental status, vision loss. There's white matter, vasogenic edema in the posterior occipital lobes and parietal lobes. It's commonly associated with acute hypertension, and several clinical conditions can be associated. It sounds like eclampsia and preeclampsia are very common. Also, end-stage renal disease patients with severe hypertension, typically managed through controlling their blood pressure, anticonvulsive therapy, and fluids. So does this relate to our patient? Possibly. She did come in quite hypertensive with a seizure, was reporting a headache, but I don't think it explains all of the other findings. So I'm assuming we're taking her to the medical ICU rather than the neurosurgical ICU. I'm going to build my differential off of these 3 findings. Again, there was so much going on through so many systems. I'm going to anchor my diagnosis on these findings. I'm an endocrinologist, so we're going to start with hypercalcemia. I'm sure my pulmonary and infectious disease colleagues would probably start in the lungs, but we'll get there. And I know very little about a rash. So the patient was mildly hypercalcemic with a calcium of 13.8. And if you ask an endocrinologist, their very next question would be, what was the PTH? So the PTH in this case was suppressed. It was less than 20. It was 6.6. So we think of hypercalcemia in 2 categories. Is it PTH dependent or PTH independent? PTH dependent is very common, primary hyperparathyroidism, familial hypocalciuric hypercalcemia, and then tertiary hyperparathyroidism of renal disease. That's not the pathway we're going. We're going down this more rare but longer list of PTH independent causes. We commonly think of granulomatous diseases, hypercalcemia of malignancy, and vitamin D intoxication. Less common would be a vitamin A intoxication. Some of these medications are common, lithium and thiazides. Abaloparatide and teriparatide are osteoporosis treatments. Hyperthyroidism, acromegaly, and pheochromocytoma can cause hypercalcemia. We do see it quite commonly with immobilization, and nowadays it's rare to see milk alkali syndrome. Okay, so PTH independent hypercalcemia. Granulomatous disease was the first one on that list, and there's a long list of granulomatous diseases. Sarcoidosis, I trained here at BCU, so I think we have a larger population of patients with sarcoidosis than other parts of the country. Tuberculosis has to be on our list. The patient has a left upper lobe cavitary lesion. Other more rare infectious things, Langerhans cells, histiocytosis, silicone-induced granulomas, we've seen that in patients injecting silicone, talc granulomas. Can't forget about the rheumatologic disorders like granulomatosis with polyangiitis, and then more infectious causes. But they gave us a long list of infectious causes, and infectious disease is by no means my strength, but they gave us negative antigens for crypto, coccidioides, histo, Bartonella. They gave us negative rheumatologic markers for the granulomatosis with polyangiitis. They gave us 3 negative AFB cultures, negative blood cultures, but an indeterminate quantiferon gold. I might be stuck here. Wasn't quite sure what to make of this, had to phone a friend. You might be holding back some information about this indeterminate quantiferon gold. It remains a question for me. Is that going to be pertinent to our case? The quantiferon gold test, in my limited knowledge, tests against 2 antigens, tests against a mitogen positive control and a negative control. And perhaps the indeterminate result is telling us that her immune reaction wasn't enough to interpret the quantiferon result. So maybe there's something abnormal about her immune system. Her CPC had a mild anemia. It had thrombocytopenia. It had a white blood cell count of 7.7 and a relatively normal differential to me, 76% neutrophils, 14% lymphocytes. So I'm not sure what to make of this. I've left it in italics because it remains a question. We'll see if it's pertinent. Hypercalcemia of malignancy was the second, probably most common one on that list of PTH independent causes. 3 main mechanisms of hypercalcemia from malignancy: PTHrP secretion, which is typically from our solid tumors. Lung cancer is one of the big ones. The PTHrP is a similar molecule to PTH. It causes reabsorption of calcium from the kidneys. It causes loss of phosphorus. It causes resorption of calcium from the bone. And there's actually an uncoupling there of bone turnover. So you get more influx of calcium from bone. It is less likely to stimulate the 1-alpha hydroxylase in comparison to PTH. So the 125 vitamin D result may be variable. So typically think of that in solid tumors. Osteolytic metastases is when there's bony destruction mediated by osteoclasts. The tumor cells produce factors that stimulate the osteoclast in the local environment. We typically see that in solid tumors. Breast cancer is the one that comes to my mind. She did have some sclerotic skeletal foci, so maybe there's something there related to a metastatic process. The third mechanism of hypercalcemia of malignancy is the production of 125 vitamin D, and that's the active form of vitamin D, calcitriol, that causes increased resorption of calcium through the GI tract. And typically we see that in a lymphoma. We also see that in a granuloma that activates, the macrophages activate 1-alpha hydroxylase. So they gave us an undetectable PTHRP, so it's not that mechanism. They gave us an elevated 125 dihydroxy vitamin D or calcitriol level, so we need to pursue that farther. And she has a normal 25 hydroxy vitamin D, so this is not vitamin D toxicity. Remember, the 1-alpha hydroxylase is predominantly found in the kidneys. It's activated by PTH. It's inhibited by FGF23 through a high phosphorus level. And then you get the conversion of 25 hydroxy vitamin D to 125, which is going to be the active form. So knowing now that we have an elevated 125 vitamin D, I'm thinking a granulomatous disease or a lymphoma. Could it be a different malignancy? It could be. I'm sure our oncology folks can say that there's always a cancer that doesn't follow the rules. But typically the 1-alpha hydroxylase producing 125 dihydroxy vitamin D is going to be something like a lymphoma. So now let's look in the lungs. There's a lot happening in the lungs. There's a 3.4 centimeter cavitary lesion in the left upper lobe. It's next to a solid spiculated nodule. There's multiple areas of mediastinal lymphadenopathy, and there's widespread bilateral airspace disease. So I broke these down, and we can look at them independently and see what fits. The cavitary lung lesion. We can't ignore tuberculosis. Aspergillosis would be common with a cavity. That cavity could be growing a fungus, so a mycetoma. It could be a pulmonary abscess. We could have something like MAC, so non-tuberculous mycobacterium. This could be a primary lung malignancy. Squamous cell carcinoma commonly causes hypercalcemia. Again, typically through the PTHRP pathway. This could be a MET from a different primary. This could be sarcoidosis. Again, the vasculitis is on there. Lymphoma is on there. I needed to learn a little bit about this. Lymphoma is like a black box to me, but mucosal associated lymphomas can come up in any lymphoid tissue. So we commonly think of them in the GI tract, but they can be bronchial. So it could be a solid mass from that lymphoma. And rheumatoid arthritis could also present with a lung mass. So that's a long list. Some things are overlapping. We were thinking about a granulomatous process. We were thinking about a lymphoma. We talked a little bit about the possibility of this being infection. I think that's still on the list, but maybe not the primary process. Maybe she had the start of a process and now she's acutely ill and infection is coming. Lots of adenopathy through the mediastinum could be reactive to an infection, could be heart failure, volume overload. Again, could be malignancy, sarcoidosis, or lymphoma. And then she has this bilateral airspace disease in a tree and bud pattern. Tree and bud to me sounds like infection. Could also be tuberculosis. So wasn't going to be the top of my list. They gave us 3 negative AFB cultures and an indeterminate quantiferon gold. I think she could have aspirated. She had a seizure. My guess is she was intubated in the field or on arrival. So maybe this is something that is developing through her hospitalization and illness, but wasn't the original pathology that led to the widespread findings. So things are overlapping: sarcoidosis, granulomatous diseases, lymphoma, sarcoidosis, lymphoma, and maybe there's a secondary infection. They gave us the other negative infectious disease workup. So somebody found a rash. It was on her tattoo. It was papular and erythematous. Could this be an allergic reaction to the tattoo? We don't know how recently the tattoo was placed. Could it be a foreign body reaction? My understanding is there might be more reaction to a red ink. This could be an infection. Again, it could be sarcoidosis. So it's well documented that sarcoidosis commonly presents with erythema nodosum. It can also show up as lupus pernio, but the papular rash or the granulomas can form in old scars or tattoo sites. So that's a picture from a New England Journal of Medicine article of what sarcoidosis may look like on a tattoo. But there were more organs involved. So there was hepatosplenomegaly, there was an elevated alkaline phosphatase, an elevated GGT, and these scattered sclerotic foci on the abdomen pelvis. I'm narrowing the differential to sarcoidosis as the granulomatous process, more likely than infection, given what they gave us as negative testing for various infections. Or is this hypercalcemia of malignancy? And I would guess that it would be a lymphoma because of the elevated 125 dihydroxy vitamin D. So then you pull articles and review articles about what sarcoidosis may look like through various organs, and it can affect every body system. Lung involvement being most common. The hypercalcemia of sarcoidosis is due to the 1-alpha hydroxylase activity of the macrophages in the lungs and lymph nodes, and this is a PTH independent process. So that fits for us. Typically, the pulmonary involvement has 4 stages, can then progress from only lymph node involvement to fibrotic parenchymal disease. Most patients are going to have bilateral hilar adenopathy. They can see nodular opacities along the bronchovascular bundles. These can also conglomerate and form like a galaxy sign. But I did find case reports of cavitary lesions. So maybe this spiculated lesion is a conglomerate of nodules, and then it has cavitated. In those with sarcoidosis, you can see abnormal liver function tests in up to 35%. Most commonly, the alkaline phosphatase is elevated. Now, it doesn't tell us if that's coming from liver or bone in our case, but she did have an elevated alkaline phosphatase. Hepatomegaly can be seen in 5 to 15% of patients with hepatic nodules in less than 5%. She had some small nodules, but she did have an elevated GGT. The splenomegaly, in my mind, would explain the sequestration of platelets, and the anemia wasn't all too severe. Her hemoglobin was 11.8. Sclerotic bone lesions. I had to look this one up. I had to dig into what sarcoidosis may look like. Typically, it occurs in the hands, the ankles. They can present with an arthritis picture. They can have cystic radiolucent areas. They can have lytic lesions in the vertebrae, but they can also have these sclerotic lesions. So maybe that fits with sarcoidosis. Neurosarcoidosis typically would start with cranial nerve involvement. They can have a facial nerve paralysis, but 50% develop parenchymal brain disease. They could also present with an aseptic meningitis or peripheral neuropathy. I can hypothesize that her seizure was due to neurosarcoidosis. What about hypercalcemia of malignancy? I think less things would fit this diagnosis. I think because of the elevated 125 dihydroxy vitamin D, this would need to be a lymphoma. Presenting in the lung, that would have to be the MALT. She did have unintentional weight loss, so maybe that was her B symptom. She does have thrombocytopenia, so maybe something happening with bone marrow. To me, it doesn't explain the rash, and it shouldn't really explain these sclerotic bone lesions. So the test to confirm diagnosis, I think we're lucky here. I still have some friends in pulmonology, and the pulmonologists are pretty friendly. that's who I would consult. And I would say, can you look at these pictures? Can you get us a bronch with a BAL, make sure this isn't infectious? And what can you biopsy? Can you biopsy a mediastinal lymph node, or can you get to this left upper lobe lung lesion? I'm hopeful that our expert is going to show us some biopsy pictures that are a non-caseating granuloma if this is sarcoidosis.
Awesome. Thank you, Dr. Vargo. So now I would like to turn things over virtually to our case expert. Dr. Evan Dombrosky is a rheumatologist at the Richmond VA Medical Center. Dr. Dombrosky completed his undergraduate education at University of Virginia and received his MD from Eastern Virginia Medical School. He then completed his internal medicine residency and rheumatology fellowship training here at VCU. He is a first-year rheumatology attending at the Richmond VA Medical Center.
Hello, can you hear me okay? Just need somebody to stop sharing that screen. Oh, perfect. Okay. Let's see. All right, working on it. Is that right? Or was it the other way?
Yeah, no, sorry, that looks great on our end.
Looks good. Okay. So thanks for having me. Sorry I'm not there in person, but we got clinics starting at 1:00. But yeah, happy to review this super cool case with you. I have no disclosures. And our diagnosis, without further ado, was sarcoidosis based on a biopsy of mediastinal lymph node showing non-caseating granulomas. So I just want to tell you a few things and hopefully not bore you, but I just wanted to start off by showing you the etymology of sarcoid. It really just means flesh-like condition from Greek. So I don't think all of us think of it as that, but that's kind of where it came from. So flesh-like condition, it can do all sorts of different things, just about anything really. You know, it can do this. Oh, sorry, one sec. Okay. Sorry, swap again. So yes, it can do pretty much anything, and I don't want to ignore that. You know, Dr. Vargo did a great job of outlining how it was clinically evolving in this patient and what we were seeing. But you know, one of the things that Dr. Vargo touched on was that tattoo reaction, which is somewhat specific for sarcoid. It can look quite different, and it can be these, you know, rare nodules, or it can be the whole tattoo looking kind of raised. But Dr. Vargo did make a hint towards, you know, the dyes as being a causative agent sometimes, and it is apparently the pearl here is that multiple dyes should be involved rather than just one dye, which could just indicate that they have an allergy to something. But anyways, that was an interesting finding in this patient, and no, that picture is not from our patient, that's online. So anyways, you know, we could talk about sarcoid for a long time, but I figured I'd focus on the mythical granulomas, which this National Institutes of Health illustration describes as inflamed lumps. So we got inflamed lump, fleshy skin disease, which isn't necessarily wrong, but you know, if you're trying to understand this and explain it to your patients, I don't think you're going to want to tell them they've got inflamed lump flesh disease. So what should we say, and you know, how do we demystify the granuloma? So I just want to spend a couple of minutes doing that real quick. This is just an illustration of the lungs at the level of the alveolar space, zooming in on the function of the alveolar macrophage here. Oh, got a laser pointer. So, you know, the alveolar macrophage is super important for innate immunity. They're all over, you know, within the alveoli and protecting us all the time from different things. But it's theorized that in sarcoid, there's some sort of antigen that gets eaten up by these macrophages, presented to the immune system. It leads to your granulomas and your downstream disease. So I like this illustration of the granuloma because it demystifies it a little bit. You know, it's essentially this walled off, distinct histopathologic structure, and you can see that, you know, it's primarily made up of these what they call epithelioid histocytes, but really they're just fancy macrophages. And they're just kind of in there forming tight junctions amongst one another to make a kind of a tight walled off sort of sequestration area to keep infection away. And some of these histiocytes or macrophages can fuse together to make giant cells. Sometimes we do see that. And then they're kind of surrounded by this rim of lymphocytes, which are usually CD4 positive. I just want to make a plug here. You know, the term granuloma gets thrown around a lot. We see it in different contexts, and it doesn't always refer to this. So just be careful, and you know, don't get this mixed up with other things like pyogenic granuloma. You know, that's just referring to kind of granulation tissue. Rather than this histologic structure. Same thing with, you know, radiologists calling granulomas on chest x-rays. They're usually just describing calcified nodules, and, you know, some of those could be granulomas, but not all of them are. So just be careful with terminology. So I thought this was another nice illustration from osmosis, but, you know, we do think about, or you've heard caseating, non-caseating granulomas, and that does carry some importance if we see that or not. You know, this picture here is supposed to be illustrating some necrosis or caseation in the center of the granuloma here. And so why is it an important histologic distinction? Well, the majority of cases of sarcoid should be non-caseating. Typically, you don't see that central area of necrosis, but you know, like anything in the autoimmune world, it can present how it's not supposed to. So we can see caseating or necrotizing granulomas, but you know, we feel a little bit better if it's non-caseating, and maybe perhaps pursue a little bit of a more infectious workup if we do have caseating granulomas. And the rest of this just kind of goes over the pathophys. I really don't want to spend much time here, but again, it's, you know, antigen from macrophage presented to CD4 T cells, and then we release, you know, all sorts of inflammatory cytokines, and downstream effect is the release of TNF alpha too. So, you know, what causes sarcoid? That's what most patients are wondering when they hear about this. Well, there's lots of things. I mean, the epidemiology is kind of fun because it's so variable depending on where you go and where you look. There is, you know, pretty consistent signal of, you know, African Americans and women being at higher risk, but geographically you can go to different areas and hop around, and it can vary so much, such as in Eastern Europe, Japan, they have super low rates compared to North America. And there is some genetic predisposition, probably about anywhere from 5 to 20% of those who have a first degree relative with sarcoid might develop it themselves, but as you can, you know, that's not ridiculously high, but still spooky enough. So other exposures that have been looked at and thought about, different, you know, metals and occupational things, beryllium, zirconium, aluminum. There's a nice anecdote that lots of sarcoid researchers like to look at, which is the World Trade Center collapse, where, you know, people who were in the vicinity and exposed to the dust, there was like a 4-fold increase in sarcoid incidence in the following year, and then it kind of dropped back down to baseline levels. So there is something about, you know, maybe inorganic materials as a causative agent here. Infectious agents have been looked at heavily because, you know, this sarcoid acts so similarly to, you know, as if you had a mycobacterial infection. But, you know, there's also cases where they can't really find any you know, mycobacterial antigens or anything. Another infectious agent is Cutibacterium, is thought to be implicated, and a lot of people who have sarcoid end up having, you know, detection of certain antigens to this. But and then there's other innate antigens that perhaps the body just kind of decides it's going to attack those. And an interesting one here is vimentin. I mean, this the reason I find this interesting is that it's one of the core theorized causative antigens in rheumatoid arthritis when it gets citrulinated. And so this all kind of just maybe shows a shared, you know, origin to some of our autoimmune diseases from these alveolar macrophages just doing their job, but you know, something goes awry. Annoyingly, smoking might be slightly protective, you know, kind of like how we learned ulcerative colitis might be protective, but we're not, you know, going to tell our patients to go smoke to prevent this. So So anyways, Dr. Vargo did a great job of going over the granuloma differential, but real quick, I kind of just want to tell you, like from a rheumatologist perspective, when we get a biopsy, it's granuloma, what are we thinking about? Obviously, tuberculosis and fungal infections. We like to see an attempt at ruling these things out if patient's at risk for it. We don't require everyone to have all these things be tested and be negative, but if it's caseating or they have maybe some exposure to these endemic areas, you might want to dive a little further there. Other things that we think about with granulomas, inflammatory bowel disease like Crohn's, and as Dr. Vargo mentioned, GPA. And lymphoma. I mean, that's the big scary thing, right? We want to make sure we're not treating a cancer with immunosuppression. So though this is not an all-inclusive list, but again, as long as there's an effort to kind of rule out some of these more common or more devastating things, then sometimes we'll feel comfortable just going forward without necessarily ruling out all of these things. So sarcoid, who comments on it? The American College of Rheumatology and the European equivalent don't really have classification criteria or treatment guidelines. So, we look to other places, but it's, a lot of anecdotal evidence. Each drug can make a case in different scenarios of sarcoid, and it's kind of confusing. But thankfully, American Thoracic Society, Respiratory Society, and this World Association of Sarcoid and Other Granulomatous Disorders, WASOG, they suggest kind of the following for classification criteria, for enrolling patients in studies, but I'm not sure how helpful this is. They basically say, make sure it's compatible, make sure you've excluded everything, and you have some granulomas. So, I mean, I understand why I have to do that for research purposes, but it's not helping people make diagnoses in the clinical world. You don't always need biopsy. You can have a pathognomonic presentation of a form of sarcoid, such as Lofgren's. There are others, but this is the more common one, and that includes Byler, hyaladenopathy, and 3 of the following. They're supposed to be less than 40, although I'm not sure that's reliable either, since a lot of patients with sarcoid can present in their 40s, 50s, and even 60s. They are supposed to have erythema nodosum, inflammatory arthritis of the ankles, and a relatively recent onset of symptoms, since Lofgren's is kind of an acute inflammatory state. That does typically resolve on its own after time. Some patients need NSAIDs, and rarely do they need more than that. So I want to give you some clinical pearls here and just thoughts on different things we talk about with sarcoid and think about. I want to mention the ACE level because I think we all check it and we want to check it and feel like we're doing something, but it's really not that helpful. A lot of patients have it elevated and others don't, and it doesn't seem to correlate with disease activity or anything. So, you're welcome to order it and tell us about it, but in terms of weighing, whether someone has sarcoid or not based off an ACE level, we don't really use it. And again, yeah, there's other reasons ACE can be elevated: granulomas, infections, cancers, other autoimmune disease. Not to mention, lots of people are on ACE inhibitors, which may reduce this effect of the ACE elevation. As mentioned by Dr. Vargo, pulmonary manifestations are the most common. And brings us back to the pathophysiology with the alveolar macrophages. So when I'm seeing with somebody with probable sarcoid, I'm looking for other organ system involvement to kind of confirm the diagnosis and feel more comfortable. So I'm asking about things like inflammatory arthritis. I'm looking at their imaging for hepatosplenomegaly. Asking about their ocular history. Do you have any unexplained inflammation? Have you had a history of uveitis? Things like that. Nervous system involvement is rare, only maybe 5% of the time, but it can range from anything like Dr. Vargo said to a facial nerve palsy to whole brain leptomeningeal inflammation, and it's tough. But whenever you're dealing with this, and the key point is to look elsewhere and try to find your biopsy site elsewhere. Nobody wants to be biopsying meninges if they can avoid it. So, and again, even though you'll read about percentages of different organs being involved, just remember that it can affect everything. I mean, even some weird, organs that we don't talk about as much. I think there was some data showing that autopsies on patients with sarcoid ended up having like tons of granulomas in all sorts of different tissues. The majority of patients had it within their muscle, but only, you know, a small percentage, less than 10%, were ever diagnosed or had clinically apparent, you know, muscle involvement or something. So it's perhaps more widespread than we give it credit for. So what am I doing when I have this new sarcoid patient? You know, basic labs, if they're kind of doing well and doing okay. Obviously the quantiferon is nice. If you can get it, an indeterminate result, you know, tough to say what to do with that. Usually I just repeat it if I didn't expect it to be indeterminate, but if they've had latent TB in the past, or if they're on prednisone, you know, these things can potentially give you an indeterminate result, and it's not as helpful. So basic imaging, I try to get in every sarcoid patient, you know, at least a chest X-ray to determine their hilar adenopathy, if any, EKG to look for signs of conduction abnormalities, and they should get regular ophthalmologic exams. Other things to consider, you know, we have a whole toolbox of things that we do depending on what patients are complaining of. And, you know, we do like having CT chest, abdomen, pelvis on file just to know the extent of organ involvement, disease activity, or you know, even just knowing where there's bulky lymph nodes can be helpful for a baseline moving forward. Sometimes we get deep into the cardiac workup, especially if there's palpitations or more severely syncope. You know, we do all sorts of things: cardiac MRI, cardiac PET, and this is a different type of PET from your normal whole body. So just be aware, we can't make conclusions about the cardiac tissue based off a regular PET. Neuro workup, I mean, this is usually kind of done for us with the help of the neurology team. Getting MRIs of suspect regions and getting a lumbar puncture is helpful too sometimes to rule out infection and demonstrate a lymphocytic pleocytosis. Sometimes you can get a bone marrow biopsy if you've got, you know, pancytopenia or something else that's unexplained, and you're trying to define granulomas in there. But you can also have granulomas in the bone marrow and not have pancytopenia, so it can be challenging. Vitamin D, as Dr. Vargo mentioned, sometimes we order the calcitriol to see, you know, we don't do this routinely in patients, but if we're kind of worried about a sarcoid patient and maybe their vitamin D is low, we want to know if we should replete or not, we can check this calcitriol to see, you know, if it's very high, then perhaps you should not replete their vitamin D. And then again, ACE, I'm not too big of a fan. There is this test called lysozyme that's supposed to be slightly better than ACE in picking up sarcoidosis, but again, it's not going to rule in or rule out disease. So getting briefly into management, I mean, a lot of patients with sarcoid will just kind of go on with their life and not ever get treated with anything. So sometimes we do all this big workup if we see some lymph nodes, but it's warranted. I mean, we need to make sure there's no infection or cancer, but a lot of times we can just kind of watch them if they're not symptomatic. So usually what we try to do is stratify, you know, how many more organs are involved and how severe is it. In mild disease, we're using things like hydroxychloroquine, which is nice because it doesn't really suppress the immune system. There are other DMARDs. Methotrexate is a common one we use. For more moderate, you know, slightly more concerning patients, you might escalate to TNF inhibitors. We prefer infliximab. It just has the best data in sarcoid. Adalimumab is also you know, shown to be probably, you know, just as good, but again, infliximab has the more data, and we do avoid etanercept or Enbrel just because it doesn't cover inflammation in the eyes, such as uveitis. And then sometimes you're adding in prednisone. And again, severe disease, as in we have in this case, you're going hard with the immunosuppression. You know, you're probably pulsing these people using TNF inhibitor or cyclophosphamide, often adding another DMARD as well. So we can do any combination of these things. There's all sorts of other newer drugs being looked at, but these are kind of the mainstays. So, and these are just other things that might indicate severe disease, you know, severe hypercalcemia, if they were symptomatic, refractory uveitis, cardiac involvement, and sometimes in rare cases, you know, refractory diffuse skin involvement. So getting back to our case, the involvement is severe, and, you know, she's got all this respiratory involvement, which as astutely pointed out by Dr. Vargo, could represent aspiration, but sarcoid can make this kind of alveolitis sort of picture in its acute phase. So it potentially could be all, or mostly all sarcoid. So this is probably what I would have done for our patient. I'm actually not sure what they received because I don't have access to Epic at the moment, but I probably would have pulsed this person, put them on, prednisone 1 mg per kg per day, taper slowly every couple weeks, maybe by 5 milligrams. You could do infliximab infusion or cyclophosphamide infusions in the hospital for induction therapy. There's concerns for both. With infliximab or TNF inhibitors in general, we worry about demyelinating signal that is seen in TNF inhibitors. People who perhaps have MS might be exacerbated when they start a TNF or something. So whenever there's neurosarcoid, we have to think about that. But hard to interview this intubated patient, I suppose, and examine them well. And then cyclophosphamide we worry about with reproductive concerns. It's debated on how significant this is, but the older a woman is in their reproductive years, this woman was close to 40, the higher the chance of causing premature ovarian failure is with cyclophosphamide. So would probably lean towards infliximab here, but. And then you could add on something else, just thinking that, one medicine might not be enough. We like mycophenolate and methotrexate a lot. Azathioprine has a lot of data in the past and can be used, but we nowadays try to add one of these if we can. And then again, consider hydroxychloroquine, although in the short term, that's not going to, manage these symptoms. It's really your high dose prednisone and your early infusion that's going to get things under control. And just since I'm a rheumatologist, I have to make a plug for, whenever you put someone on long-term steroids, consider vitamin D supplementation. Obviously, that's a bit more nuanced in a sarcoid patient. Consider an antacid, H2 blocker, PPI, and have a risk-benefit discussion, if you can, about, prophylaxing against pneumocystis. All right, so that's all I had. This is what the VCU marketing team had on Facebook. So they describe sarcoid as disease causing your immune system to overreact. It can cause lung damage, skin rashes, eye disease, affect other parts of the body. It causes clusters of inflamed tissue. I think that's pretty good explanation, for patients. I wouldn't recommend doing what I did the first time, which was you got little balls of inflammation inside of you for attacking, unknown infections, and that just freaked out the patient. So, it is nuanced how we have to discuss this. And then lastly, real quick, WASOG, this is the World Association of Sarcoidosis, Granulomatous Disorders, and we do have a center of excellence here, within rheumatology. Dr. Huzaifa Syed is heavily involved with that, so very proud of that. But all right, thank you.
All right, and now we will open it up to questions for our expert. Yes, Dr. Dow.
So another possible source of tissue for this patient, because that seems to be the real big issue, is the tattoo and the skin lesions. And I just wonder what the utility and outcome of a skin biopsy is compared to doing something more invasive, like going into the lungs. And also sort of the cosmetic effects of that. Is it going to make the sarcoidosis on around the tattoo worse and cause all sorts of problems? So maybe, I don't know if Evan knows pros and cons of that as an option.
Yeah, so just to repeat the question, wondering about the utility of a skin biopsy versus a more invasive approach and whether that might exacerbate the existing skin lesion.
Yeah, no, I mean, it's a great thought. I think if you didn't have access to, endoscopy or something, at least finding a granuloma somewhere in this person would certainly be helpful. I guess the main concern is this person has bulky lymphadenopathy, bone lesions, and how do you really say this is not a lymphoma, and that even if they had granulomas in their skin, I guess it's not common to certainly have two separate diseases, but I just think you might still have something in the back of your mind if you only do the skin biopsy. Yeah, that you're not treating the right thing. You also don't get your nice acid fast stains and rule outs there with the skin. So yeah, it's a good point. And again, if you could not get a lymph node, or if this patient had no lymph nodes, I mean, sometimes we get neurosarcoid with zero lymphadenopathy throughout the chest or abdomen. So that might be an alternative. Yeah.
Yes.
the chat.
I was gonna, any other questions from the audience first? Okay. So just some, Dr. Nandan had a point, that indeterminate quantiferin on sarcoidosis patients who do not appear to clinically have TB. Sarcoidosis itself can, in advanced cases like this, can be a leukopenic condition with CD4 counts innately being low due to the condition. And this may be a reason for the analgesia in patients leading to indeterminate quantiferins.
Yeah, it's a good point. And especially with extensive respiratory involvement, it is thought that you're kind of just throwing out all your CD4 T cells, into the alveoli, into the lymph nodes, and there is some sequestration effect. And you should see on BAL, you should see increased CD4 lymphocytes, right? And then on peripheral blood, you might see lymphopenia, just due to that sequestration. So yeah, great point.
Any other questions? All right.
Make a comment. I would remind everyone that we have sort of super expertise in sarcoid. You mentioned Josefa, Jordana Krohn in cardiology. If you're not sure what the right imaging is and you're concerned about sarcoid, then obviously only teams at both sides. But we do have a very deep bench for second opinions and health with patients with sarcoid. And also a great opportunity for clinical research at the VAMC.
Very good. Well, thank you, Dr. Vargo and Dr. Dombrosky.
Thank you.